I'm Alan Leshner. I'm the Chief Executive at AAAS, and I get to welcome you to what actually is my favorite series of Hill briefings that we have, only in part because I'm a neuroscientist myself. This is the second of the AAAS Dana Foundation jointly sponsored series of brain briefings, and we are, as always, delighted that our main brain supporter in the U.S. Congress, Chaka Fattah, is with us, and I'll give him the podium in just a minute. This particular briefing is on the topic of spinal cord injury. We have three terrific speakers for you. Spinal cord injury, of course, has only become a more and more important topic, both for sort of the general population and the variety of ways in which spinal cord injuries can be caused. But I would say that in addition to that, the returning veterans have had a particularly large number of spinal cord injuries, and therefore the issue has become even more important, both for policymakers and the rest of the public. One of the nice things is that recent studies have been changing the way in which we think about the prognosis for recovery from spinal cord injuries and the ways to deal with patients with paralysis caused by them, and you'll hear some of that today. What I'd like to do first is to introduce our partner in this activity, Congressman Chaka Fattah. As I hope everybody knows, he's from Philadelphia, an incredibly important part of the United States. I happen to come from Philadelphia myself. And Congressman Fattah has had an extremely strategic career here in the U.S. Congress, but among other things, he is the ranking member of the House Appropriations Subcommittee that, in fact, is responsible for appropriations for many of the most important science-supporting agencies. He is a well-known big supporter of science generally, and in particular of neuroscience. And I hold him responsible for President Obama's Brain Initiative. He has done extraordinary things, both nationally and internationally, to bring together the global neuroscience community. And he isn't even a card-carrying neuroscientist himself. That notwithstanding, he's an honorary neuroscientist. So with great pleasure, Congressman Fattah.
Well, first of all, everyone should enjoy their lunch. You're going to obviously be greatly stimulated by our guests. Let me say a few things. One is that last night I got a chance to jump inside of the new SpaceX human flight space machine developed by Elon Musk, and that was exciting. But there's nothing more exciting in all of our scientific enterprise than the work that's being done in neuroscience. And when we think about this, SCIs are an increasingly important area. And I want to thank the Dana Foundation and AAAS for hosting and supporting this briefing. And for, I think if you want to put any three experts together on this subject, you could not have a finer group. Dr. Young and Pettigrew and Bunge, who bring different perspectives but expertise that I think will enlighten and inform our thinking about this. But let me say a couple things. 2 years or so ago, I visited UCLA, and there was an international team there doing some work on how to stimulate neurons below the point of injury, and to a remarkable degree of success. On last week, I had a young woman who's been paralyzed for 20 years. Vietnam veteran, walk into my office utilizing the ReWalk system, which was the clinical trials were held in my district at Einstein, but this was developed a project between both an Israeli and U.S. Philadelphia-based collaboration, and it's doing, just it was just phenomenal. We see now some great excitement in the stem cell research around literally repairing in a restorative way the actual injury point. So, and I guess when the World Cup, you're going to see a actual example, in terms of what's possible in terms of creating mobility where there have been paralysis. So there's so much excitement in the field. And the reality for the work that I'm engaged in on this broader area of neuroscience, this is the kind of disruptive progress we want to make. And you can see that the work is taking place in a variety of different approaches. And I think all are going to be necessary. So I want to thank our guests. I'm looking forward to hearing their presentation. We are in the middle of an appropriations committee upstairs on Homeland Security, and if I'm called away, it'll only be for a vote. So I don't want anyone to think that it's because of your presentation and that if I have to depart. But my chief of staff, who's actually the genius among us, is here, Ms. Leek. So I will yield and back to our very capable moderator and the leader of the world's largest scientific society, Alan Leshner, to guide us through this. Thank you.
Terrific. Thank you very much, Congressman. Okay, so again, on behalf of AAAS and the Dana Foundation, excuse me for speaking for the foundation, but the Dana Foundation, in case you don't know, is the major supporter of brain research among private philanthropies and supports a wide variety of grants and educational programs and outreach programs around neuroscience. So they are wonderful partners. So we have 3 speakers today. They've each been asked to hold their remarks as close as they can to 15 minutes. Wish us luck. Among them are academics. We know the problem. And actually, I'm going to describe the 3 speakers first. They will then speak in order. And then they'll form a panel up here, and you can ask them questions. For those of you who've been to one of our briefings before, let me once again define a question. It's short. It doesn't have a preamble, right? And your voice goes up at the end. Got it? Okay, that's the routine. All right, the 3 speakers and the order in which they'll speak: Dr. Mary Bartlett Bunge, who's the Christine Lynn Distinguished Professor in Neuroscience, Professor of Cell Biology and Anatomy, Neurological Surgery, and Neurology at the Miami Project to Cure Paralysis at the University of Miami. She'll then be followed by Dr. Roderic Pettigrew, who's the Director of the National Institute of Biomedical Imaging and Bioengineering at the National Institutes of Health. I think is spectacular to have him with us. And then the 3rd speaker will be Dr. Wise Young, who's the director of the W.M. Keck Center for Collaborative Neuroscience and the Richard H. Schindel Chair in Neuroscience at Rutgers University. I might point out, in addition to my association with Philadelphia, I happen to have gone to graduate school at Rutgers, so we're particularly happy to have you as well. Okay, let's start with Mary Bunge. And after Dr. Bunge, people will just follow in turn, and then we'll do the panel.
Well, good afternoon. It's a pleasure to be here, and thank you very much for the invitation to invite me here. So what I want to do today is to introduce 2 tetraplegics to you and to talk about the challenges that they face every day, and then welcome you to my laboratory to hear about some of the research that we're doing, and then finally to give you an idea of what it took for us to go from the lab bench into a clinical trial. This is a C3-4 high tetraplegic, and there's no use of the arms or legs. They're dependent on a nurse or an attendant constantly, and at least 3 times a week when bowel evacuation is done, takes 4 hours to get ready to face the day. This person catheterizes his bladder every 5 hours. So his concerns are sitting very comfortably in the wheelchair and worrying about his urological status. Will he have a bladder infection? And he worries about his temperature or his blood pressure spiking. And he figures it costs him about $600,000 to $700,000 a year. So then next, the C5 low tetraplegic, a young woman. She has partial use of her arms, very limited use of her hands. She's dependent on an attendant twice a day, in the morning and in the evening. She does not have insurance. She worries about finding reliable help long term. She has an indwelling bladder catheter, and she worries about the maintenance of that, worries about her wheelchair function. She worries about accessibility to wherever she has to go. So the quality of life issues are huge and a very, very complex. In addition to the muscle paralysis, which you see, when you see a person in a wheelchair, that's only the beginning, because they have a loss of feeling, reduced pulmonary function, blood clot formation, which can be life-threatening, early cardiovascular disease, lack of bowel and bladder control. And as I mentioned, temperature and blood pressure may peak, also life-threatening. And pressure ulcers, osteoporosis, sexual function is impaired. And about 80% of persons with spinal cord injury develop long-term pain, obesity, diabetes. So you can see how complicated this is. So just a few statistics. So there are 12,000 new cases a year, about 1.25 million Americans with paralysis due to spinal cord injury, but up to 5.3 million they have paralysis without spinal cord injury. The cost is huge, and so for the first year for high tetraplegic, it's over $1 million. So what happens? The problem is that there's a disconnection between the brain and the spinal cord. And so how are we going to fix this? So I mentioned that the issues for the person in a wheelchair are complex and many. The same is true of the tissue in the spinal cord after injury. So there are many pieces of this puzzle that we have to put together. And so what I have done, I've chosen the transplantation route to put cells into the area of injury, because the damaged area of the spinal cord is a hostile environment for regeneration. So I'm putting in cells that will make a difference in that environment. And I'm choosing Schwann cells. These are not stem cells. These are Schwann cells for a number of reasons, and that is, we know that they promote regeneration in the nerves in the arms and legs. And this is where regeneration occurs naturally, and that's because of the Schwann cells. So if they can promote regeneration in peripheral nerves, then why not in the spinal cord? That was our rationale. They produce growth factors, they produce myelin. Myelin is very important to be around the axon because it helps the signal to pass along the axon. And why I have stayed with Schwann cells for decades is because we can take a piece of peripheral nerve from a spinal cord injured person's leg, and we can extract the Schwann cells, then we put them into tissue culture, and we can raise 100 million Schwann cells about 3 weeks. And then we can transplant them into the area of spinal cord injury in the same person. So we are avoiding an immune response. Next. So this is one of the outcomes in spinal cord injury, and this is the spinal cord is here, and this is a big cyst. This is in rats at 12 weeks. Now, if we transplant Schwann cells into that area at 1 week after injury, then you don't see a cyst here. You see a nice bridge across the injury, and that's because of the Schwann cells. And here we've made the Schwann cells green, so you can see the implant here in the spinal cord, which is red. Next. So what we have found with Schwann cells is not only that the cyst is reduced or eliminated, but also we protect spinal cord tissue from secondary damage, and we can support axonal growth into the Schwann cell graft. And there's some improvement in walking in rats after we have paralyzed them. Next. So what we found, whereas we saw a good result with Schwann cells, we started to think about how can we improve the efficacy of Schwann cells? What can we combine with them to make them more effective? And so we have tried a steroid, which is used clinically, and we've added a variety of growth factors and an enzyme, which the enzyme is to reduce the scar. A scar forms around the lesion to wall off the bad tissue from the good tissue of the spinal cord. The problem is that the scar also inhibits the regeneration of axons across the area of the injury. Next. So in all the combination strategies that we've tried, we have seen an improvement in Schwann cell function. And so we see that there are more myelinated axons in the graft. There's an increase in regenerated axons from neurons above the spinal cord. And those nerve cells are very important for locomotion. And we've seen an exit of regenerated axons from the graft into the spinal cord so that they can then grow down the spinal cord. And there's some improvement in walking. Next. So this shows what a difference a growth factor. So Schwann cells do secrete growth factors, but if we add more growth factors, then you can see the result here. So here the Schwann cells are green. This is the implant in the spinal cord here. And then if we add a growth factor, this is much larger because more Schwann cells have survived the transplantation, and the more Schwann cells there are, the more axons regenerate into the implant. Next. So now I'm going to tell you about one experiment in the lab, and we have red Schwann cells that are making the enzyme, and there are green Schwann cells that are making a growth factor. So this is a combination. This is a triple combination: Schwann cells and an enzyme to break down the scar, and a growth factor for better regeneration of the axons. And so this is the experiment, and this took over 200 rats, and it took us 2 years to do this. Probably cost us over $100,000 to do this experiment. So we had groups of animals with the green Schwann cells, with the growth factor, and the red Schwann cells with the enzyme, and then we put all of them together. So what worked best? So this is a slice through the tissue, and you see the implant. This is in the animal that received only Schwann cells, and you see an implant here. But this is the implant from the animal that received all Schwann cells and the growth factor and the enzyme. And you see it's a much more prominent implant. Next. And so now if we zoom into that area and look at higher magnification, then we see myriads of myelinated axons. So each circle here is an axon with a myelin sheath around it. And then we counted them, and this bar represents the combination of all, and you see 30,000 myelinated axons were in the implant. So the winner here was the triple combination. What we saw in this experiment then was compared now the combination, the triple combination, with either the Schwann cells with growth factor or the enzyme. We saw a further increase in the implant compared to the factor or the enzyme alone. Further increase the number of myelinated axons compared to the enzyme treatment. Higher number of responding neurons above the spinal cord. Higher number of their axons in the implant and also beyond the implant. So the triple combination was definitely an improvement. Now, I have to put in a plug for NIH here because they have been funding me all my scientific life. So when I became a postdoctoral fellow, they gave me a fellowship to start an additional training after the PhD. And then in 1971, my husband and I obtained an individual research grant, and we've been successfully applying for every 5 or 7 years to continue that. And so we have just entered our 43rd year of this NIH grant, which is definitely unusual. But also, private foundations are very important because when we have a new idea, we want to try it, it's too risky. NIH is not ready to fund it. So the private foundations have been very important. So now, how do we get from the lab bench to the clinical trial? And so what I see is we're going to continue with looking at combination strategies, and also we need more clinical trials. We're in the process of preparing to apply to the FDA for our second clinical trial. So how did we get there? Well, we were approved for the clinical trial in December of 2012. It took a lot of people. It took a lot of time, and it took a lot of money. We estimate that we spent $15.5 million just for the preclinical work to get to the application for the FDA. And this is very unusual for an academic institution. So we've been able to fund the beginning of the trial. When we get to a phase 2 trial, then we have to have help. But as far as we know, we're the only academic institution that's been able to start a clinical trial without the involvement of a company. So milestones. So in December of 2007, we started weekly meetings. Those weekly meetings continue to this day, and they will continue until we are satisfied with how many clinical trials we should start. So we obtained approval in July of 2012, and it took us a year. We were put on hold a couple of times because of questions that the FDA had. So it took us a year, but finally we obtained approval in July of 2012, and we've transplanted 3 patients. We had very strict exclusion criteria, and we've just gotten permission from the FDA to change some of those. So now we expect that this trial for injection of Schwann cells will go more quickly. All right, so this shows you here that there's 3 sets. This is one set of the application to the FDA, thousands of pages, a lot of proofreading. Next. So what did the FDA require? Well, we had been studying Schwann cells for decades, but they wanted to know, they wanted more proof that the Schwann cells did not form tumors, that they did not leave the implant site, what was the appropriate dose, and they wanted to see that these cells survived for 6 months. So there was we had to prepare hundreds of rats. We had to ramp up the personnel. So this is what was so expensive. We had to characterize the preparation of the human Schwann cells very carefully. The FDA has to know exactly how the human Schwann cells are prepared, and they have to approve every substance that's involved in the preparation of those cells. And then they have to know exactly how we're going to inject the Schwann cells. So, as I mentioned, this took a lot of money, a lot of rats, and our challenge was to document the outcome of every rat. There are hundreds of rats, and we had to show them the record for every rat, and that was a big deal. We had to write standard operating procedures for every step and every procedure. One of those protocols was several pages, so that took a lot of time. We had to slice up the entire brain and spinal cord so that they knew where the Schwann cells were going or not going. And then finally, we had to employ a certified pathologist to look at all those sections, thousands of sections. So, thank you very much. And one more message I have. When I was in Africa, I ran into this proverb: if you want to go quickly, go alone. If you want to go far, go together. Thank you.
Thank you, Alan, and good afternoon, everyone. It is a great pleasure to be able to share with you some of the exciting research that's being supported by the NIH that has shown significant promise, particularly in people
in the recent months and last couple of years or so. Given that I only have 15 minutes, I can only give you a brief overview, but I'll be delighted to entertain any questions that you may have afterwards. As Mary has indicated, the NIH is very active in supporting research in this area. You can see that there are a number of institutes indicated there on the left that are involved in supporting the challenge of addressing paralysis due to spinal cord injury. And the composite number here is about 75 million or so among the institutes that are indicated that was utilized, I should say, from the appropriations in 2013, specifically in this area, and the red bars indicate the percentage of the Institute's appropriation that is being used in this area. There are a number of consequences of spinal cord injury that we're all aware of. We're certainly privy to the challenges in motor and function and mobility. But in addition to that, there are these problems related to sensory loss and autonomic functions, and those are highlighted on the slide, underlined there. The spasticity and pain consequent to loss of sensation, and the autonomic functions that we all take for granted are also lost. Even something like blood pressure control or heat control is something that you may not think about. Next slide, please. So there are a number of solutions that are emerging in addition to the regenerative approaches that Dr. Bunge just talked about. In the bioengineering arena, three areas that I'd like to review quickly are assistive robotics. This was introduced conceptually by Congressman Fattah, recounting the experience that he just had with the young lady that walked into his office with a robotic suit. So assistive robotics are much like what you see in a popular movie of Iron Man series. It's an exoskeleton that you put on. It's basically a robot. The thing here, though, is that it is controlled by the individual's thought, and there is a brain-computer interface that provides that function. Functional electrical stimulation also uses a computer, but it's this size. It's, in fact, I'm holding one here that's implanted. It has several modules that deliver electrical stimulation directly to a target muscle group and can cause that muscle group to contract or relax. And in the third area, neuromodulation, in conjunction with physical therapy, is a new approach that has received considerable press in the last couple of months because of the rather remarkable report of 4 patients treated with this approach who had chronic paralysis, who now have regained voluntary motor control and also restore some autonomic capabilities. This is highlighted because I'll spend most of my remaining 10 minutes on this. Next. So here's an example of the assistive robotics. Much of the world will witness this tomorrow when at the opening of the World Cup in Brazil, Miguel Nicolelis and his research team will unveil their robotic system with a patient who is paralyzed. The patient will don this suit, stand up from the wheelchair, take a few steps over to the soccer ball and kick the ball. Next slide. Here's Miguel, and here's the robotic apparatus, the Iron Man suit. Next. And as I pointed out, a key feature here is that this is interfaced with the brain through a computer using a technology that we refer to as brain-computer interface. An example is a skull cap, actually from a researcher at our institute. This is a young child of one of our employees. Take your child to work day wearing this brain-computer interface system, connected to a computer, and she's using this to actually spell by thought. So if you look at the top of the screen, the word cats, this was spelled by this kid simply thinking C-A-T-S, those letters in sequence. the computer recognizing which letter she was thinking of and then putting it on the screen. An example of this cap is shown here by Maisha from Congressman Fattah's office. You can see it in real life in 3D. So this is configured such that it interfaces with the computer that drives this robotic system. Next slide. So that by thinking, the patient is able to control this robotic suit and take steps. And I would imagine then you think I kick this ball, and then and that motion is implemented. Okay, next slide. So that's assistive robotics. So here is the modular system for functional electrical stimulation, FES as it's referred to. And again, it uses, this is what you see in the image is I'm showing here and actually holding in my hand. Can you advance this? Click, thank you. So what this indicates is that this device has leads that interface with specific nerves that go to a target muscle or group of muscles, used here to facilitate grasping and holding in a patient who is a paraplegic and previously and without this is unable to perform that function. With this device being able to grasp, hold, and then drink from a can of beverage, as you can see. This has recently received FDA approval. Next slide. And then the third category of bioengineering-based approaches is this particularly exciting news reported in Brain just 2 months ago. This particular technique is based on the process that actually is contained in the title. Altering the spinal cord excitability enables voluntary movements after chronic complete paralysis. So this reported for the first time 4 patients completely paralyzed for several years from the waist down due to spinal cord injury at a high level, cervical or upper thoracic spine, unable to move their lower extremities at all, and in 2 patients even a complete loss of sensation. The procedure uses electrical stimulation at a very low level of the surface of the lower spine by way of an implantation of electrodes, and that this appears to change the trigger point of the neurons in the spinal cord so that they can become responsive to weak signals now. Signals from the brain or signals that are coming up from pressure and so forth, or received by the neurons, and then the patient is able to execute a motion voluntarily. The first patient studied is Rob Summers. You'll hear from him in my final video. Next slide. Here is the device itself, designed actually for pain control and not for this purpose. The 16 leads, it's the segment, the strip that you see there in the image is placed just above the spine. You click it, please. And the output from this is highlighted in this red box in terms of the functional improvement is that all 4 patients are now able to stand independently for about an hour. They've all regained some voluntary control of their lower extremities, knees, ankles, legs, as you'll see. And importantly, they have regained bladder, bowel function and sexual function. Next, please. Here's an example. Keisra, if you can click in there. Now I want you to listen to what he says. This is a patient, the first time he's doing this.
The last one time I figured out,
You're going to try more?
I figured out the motion that I needed to think of.
Okay.
It's hard to remember how to do that.
Okay, can you stop that, Keisra? So this is just a couple of days after his surgical implantation, and he's doing this procedure. It's the first time he's been able to move his leg, and what he says is, I finally figured out how I have to think in order to move, which indicates some alternate pathway that's involved, which would suggest that. But it also indicates that we really need to study this to understand the mechanism involved. If you can click to the one on the right, please. And here's another subject, similarly implanted, but demonstrating his ability to now move his left leg voluntarily. This individual was completely paralyzed before this procedure. The leads on the legs are not stimulating leads. Those are monitoring leads. They're there to monitor the contractile activity. If you can click on the inside of this, yes. Now, here's a subject who is actually standing and has the core control and the leg control in order to maintain balance sufficient to throw the ball, as you can see here. I think this is pretty remarkable. This is Rob Summers. So he was the first patient to have been studied with this procedure. And the truth is that even the researchers did not expect the dramatic improvement in voluntary function that all of these individuals have and that he had. And in fact, the first time that he told them that he could move his toe voluntarily, they thought he was kidding. And they challenged him to do it, and he did it repeatedly. The other advances, in particular the autonomic function, were totally unexpected. Here's a recording of his account of his journey from complete paralysis to this improvement in function. He was a young man at the age of 20, a baseball star, a standout in Oregon, with a pro career ahead of him, struck in the driveway by a car, hit and run accident, paralyzed from the lower cervical spine down since then. 3 years later, here's what he experiences after the epidural stimulation.
The most obvious benefit came on the third day of the experiments when I stood for the first time in more than 4 years independently. But that was just the beginning of the benefits I was about to see from the epidural stimulation project. The first thing I started to notice was an increased sensation throughout my entire body when the stimulator was turned off. This was great since now I could feel when I was uncomfortable and was able to adjust myself. This made sure that I wasn't going to get any pressure sores or skin breakdowns, which are a huge risk for people living with paralysis. The increased sensation also made me realize that my overall circulation had improved while the stimulation was turned off. I had noticed this because my skin had started to clear up and regain a healthy color as opposed to a grayish pale color. With the increased circulation, I also regained the ability to sweat. This allowed me to stay out in the heat longer and keep my body cool, whereas before I could only spend no longer than 30 minutes out in the sun on a hot day. And now that I'm able to sweat normally, I can get back outside and do the things I love, such as coaching baseball and helping out with youth organizations. The epidural stimulation has also helped my lung function. I've been able to get longer, deeper breaths while working out. I've been able to cough without any assistance, which again sounds unusual, but as a quadriplegic, I didn't have the lung abdominal strength to cough without help. So better lung function helps me in many aspects of someone who lives with paralysis. Better breathing, being able to cough, allows me to break up the stuff in my lungs to avoid certain issues like pneumonia. Some of the biggest things that I noticed that came back were the bladder and bowel function. This has given me the ability and freedom to go and do things I please. So I can go out in public, or I can go on long plane rides and not have to worry about bathroom issues or unaccessibility issues. And if you were to ask anyone living with paralysis on a daily basis what the one thing is they'd want to get back, the number one thing they would all tell you would be bladder and bowel function, so they could be more independent without having to live and rely on other people for those types of issues. I've also regained sexual function without the use of any medication or any other devices. This is very important for people living with paralysis, especially those who are trying to start families and live a normal life. All of these have come back while the epidural stimulation is turned off. But when the stimulator is turned on, I have the ability to stand with a walker now, and I can also move my toes, ankles, knees, and hips all on command, which is huge in taking the next step to literally be able to take the next step. Each one of these I've gained back or have seen a great improvement. Each one of these things I have seen a great improvement on is great by itself, but when you put them all together, it's absolutely unbelievable. And it has completely changed my life from where I was 5 years ago. It has allowed me to be independent again, but more than anything, it's given me my confidence back in who I am. So I'd like to, again, thank the NIB for everything they do, and continue to please fund all these great things so that in the next 10 years, my story will just be another regular story. Thank you very much.
Yeah. Thanks. Yes. Yeah, that was very touching to have heard that in person. And the thing that you couldn't tell, the audience really erupted in a very spontaneous, deeply heartfelt standing ovation and round of applause. As a result of the report in Brain 2 months ago, there have been a huge number of press reports, as you see listed here, from around the world. Quite a number of interviews. A few of them I've done myself and other people at our institute. In response to the tremendous hope, a level of hope that this brings to this community who has been living with paralysis without a lot of hope in the past, if you could advance that. And indeed, there have been over 1,000 emails that the research group and our institute at the NIH have received in response to the Brain report and the press coverage, all of them asking to be participants in this study. The study is rather expensive to execute, about $400,000 to $500,000 per patient. So obviously we're limited in our ability to do that, but we're now having discussions about how we can accelerate this and make this methodology available to all of the people that might benefit from it in the future. If you advance that slide, please. Go back to the last one. Perhaps in collaboration with this large number of organizations that you see here that have formed with the same goal in mind, and that is addressing and reversing paralysis due to spinal cord injury. Thank you for your attention.
Hello. I'm going to speak very quickly, and I'm so happy to be here, and I'm a great admirer of the two speakers before me, and I am very heartened by all the progress. I want to show you very quickly some results. First slide, please. So only 3 therapies have reached phase 3 clinical trial levels in human history that I know of. One is high-dose methylprednisolone, which I was involved in the 1980s and 1990s. And it showed that this drug given within 8 hours after spinal cord injury improves motor and sensory function. Then there was a trial testing monocytic ganglioside, and it showed no significant benefit at 1 year, but it seemed to accelerate functional recovery. And then there was a trial on 4-aminopyridine, which improves conduction of demyelinated axons, and that trial did not show any significant effect. So these are the only 3 phase 3 trials for spinal cord injury that I know of, and it's really sad. We need more phase 3 trials. Phase 3 trials is when the treatment has been shown to be effective. For the last 10 years, I've been working on umbilical cord blood mononuclear cells, UCBMC, and we found in recent clinical trials on 41 patients that it restores walking in 75% of patients with chronic complete spinal cord injury. And I want to show you some videos of these patients. And it also, the treatment improves bladder, bowel, and transfer functions in the patients. Next slide. So this is a picture of the actual transplantation of the cells. By the way, there's a lot of preclinical data indicating that umbilical cord blood cells are beneficial in animal models of spinal cord injury, and this is not a controversial therapy. The Pope himself embraces this, and we have been invited to treat children in the Vatican's own hospital with umbilical cord blood cells, so not controversial. This is the first patient we transplanted at the Chinese University of Hong Kong. This is the chairman of the department transplanting. This is the needle is being inserted into the spinal cord. Next slide. And this is an actual video of that patient. The dura is being opened right now, and you will see the needle being hand inserted into the spinal cord. The cells are injected into the dorsal root entry zone of the spinal cords above and below the injury site. You know, we must be very careful not to break any blood vessels on the way. The needle is placed 3 millimeters deep into the spinal cord. The injection is given very slowly over a 5-minute period. We injected 1.6, 3.2, or 6.4 million cells into the spinal cord through 4 injection sites. And it's frequently not good to show these things at lunch, but, but it's being injected. Next slide. We did diffusion tensor imaging of the spinal cords, DTI. And this shows the ascending and descending tracts of the spinal cord. You see, this is an image of that particular patient. There's a gap in the middle. This patient was 7 years after spinal cord injury. He was a complete spinal cord injury, no function below the injury site. Next slide. It's very interesting. On this one patient, at 2 years, we saw the axons grow across the injury site and reach down. And then the axons also reached up into the brainstem. We still have to prove that these are axons, but these are fibers. They're probably at least 1 millimeter in diameter, and they seem to be growing with each succeeding month. Next slide. So we did 8 patients in Hong Kong. We showed that the transplants are safe, that none of the patients had any neurological deterioration, and there was no severe adverse events in any of the patients to date. So we went on ahead and did 20 patients in the Army General Hospital in Kunming in Yunnan province in China. And these patients, after they were transplanted, were then walked 6 hours a day, 6 days a week for 6 months. This is what we call the 666 program. It's the most intensive walking training program in the world. And they go through these stages. They stand with help, stand without help. They walk with ropes behind them to lock their knees, because these patients, when they're walking 6 hours a day, their quadriceps get very tired and their knees would buckle and they would fall. So a family member usually in the back would hold with ropes to lock their knees as they're going into this stance phase. Soon they don't need any more ropes, and so on forth. Next slide. I just want to show you, I don't want you to pay attention to all the writing and so on forth. Just remember, red color means they need full assistance. Yellow means that they need minimal assistance and they can go on ahead. And green means they don't need any assistance at all. They can walk on their own. And so the stages of training are, you can see that at the beginning of the time, W0, week 0, the patients are almost all red. And there's a little bit of yellow. But as they go forward into week 24, week 28, some patients were able to walk on their own. Many of the patients were able to walk with some assistance. The scores on the right is a score, a validated score called the Walking Index of Spinal Cord Injury. This was developed at Thomas Jefferson in Philadelphia. And to make a long story short, at 1 year after spinal cord injury, 75% of the patients were able to walk 10 meters minimally, and 40% of the patients need some assistance when they did that. 35% of the patients do not need any assistance. Of those patients that are walking, and I'll show you some pictures, some videos, of those patients that are walking, when we sent them home, those that did not need assistance continue to use their walking so that they walk for up to 100 meters at a time without assistance. Those that needed assistance, they prefer to use their wheelchairs. Too much trouble to ask somebody to help, et cetera, but 35% of the patients are continuing to walk without assistance at 1 year after treatment. Next slide. This is a picture of one of the patients. 75 of the patients are walking at least at this level. This is a T4 spinal cord injury, complete spinal cord injury caused by a gunshot wound. This guy was a border guard on the top of the Golden Triangle. And he's walking like this all day long. And you can see how there's a person in the back with a rope, and the steps are self-initiated. He's balancing himself on this rolling walker. Next slide. Here's one patient. We took this at his home at 1 year. He was injured for 14 years, and he had a neurological level at T11. His actual injury site was at T10, and his spinal cord independence measure went from 48 to 74. 100 is a perfect score. His whiskey score went from 6 to 15, and he went from an Asia A, which is a complete spinal cord injury, to an Asia C, which is a spinal motor incomplete. Of the 20 patients, 5 patients converted from either A to B or A to C. Next slide. Here's one patient that did not receive any transplants, and you can see the difference in her walking. It's not as good. And this was the best of the patients who did not get any transplants. There were 50 patients like this that they had done at the center. And they have trouble initiating the gait. And of course, they have trouble sustaining the gait during walking. Next slide. And here's one patient. This patient was one of 13 patients that we transplanted at 1 week after spinal cord injury. All the other patients were transplanted at an average of 7 years after spinal cord injury, ranging from 2 to 20 years. In fact, our 20-year patient walked as well as the ones that were transplanted at 2 years. So this really surprised us. We really expected a difference. This patient was transplanted at 1 week after spinal cord injury, and you can see that he's walking around quite well. Look at his hands. He's not gripping the 4-point walker very tightly, and he's just flipping his foot. He's got household walking. He can walk for 100 meters without any difficulty. And on the right is an examination done on the same day in the patient. And actually, if we ask him to move his legs, he cannot move his legs voluntarily when he's lying down. What it seems to be doing is activating all these voluntary functions, programmed functions in the patients as opposed to voluntary functions. So we looked carefully then at the next type of voluntary programmed functions in the lower spinal cord, and that's, of course, micturition, which is going to the bathroom, urination, and defecation, which is having a bowel movement. Next slide. Go one slide more. I just want to show you these results. Green as well is not requiring any assistance. Yellow is requiring minimal assistance, and red and orange is requiring assistance. From bladder, many of the patients were catheterizing themselves. That's orange and yellow, and green is they don't need anything. And by 1 year, 60% of the patients were completely independent of all assistance when they were for bladder care. But even more shocking to us is 50% of the patients no longer use catheters at 1 year after spinal cord injury. We now need to take these patients and study them very hard with urodynamics and so on forth, figure out what the mechanism of this is. But it seems like they can not only go to the bathroom, they can hold the urine in between. And but the most surprising of all was the bowel function, which you see in the middle top. Almost every patient was dependent on some person wiping them, cleaning them, putting the suppository in, and they had to spend hours on the toilet every day. They went from that to 60% of the patients requiring no assistance at all, didn't use suppositories, they didn't need anybody to clean them. And even more important, the green indicates that they had rarely or no accidents. Now, this is the bane of all people's lives with spinal cord injury. They are deeply afraid that they'll have an accident during the day. That's why they spend 3 hours to empty out their bowels every day. And 60% of the patients have no or only rarely have an accident after, at 1 year after spinal cord injury. So we're really astounded by these results in 20 patients. Next slide. So we've now proposed a phase 4 trial to be done around the world. One will be in the US, one will be in China, then we're going to do branches in India and Norway. We want to get global approval of all of this therapy for around the world. I have to say, I've been doing clinical trials for 30 years. You must do phase 3 trials. It must be double-blind, randomized, and very carefully organized, and you have to verify these results. So I'm very hopeful that we will have a therapy that will help people attain their independence, and walking is not as good as being able to poop. Thank you.
Terrific. Let me ask the speakers to come up, please. Join us. Dr. Pettigrew, come on up. So that was fabulous. All of them were fabulous and very encouraging. At least I feel very encouraged. Okay, with that, I'll moderate. If you have a question, please. Yep. Can you identify yourself, say who you are, and you have to yell.
I'll stand up. My name is Dr. Teresa Cruz. I'm from NIH, the National Institute of Child Health and Human Development. And my question is for Dr. Young. What were you planning to do for your placebo?
Our placebo will be untethering surgery without transplantation of the cells. As you know, we always found whenever we exposed the spinal cord, there were wispy adhesions between the spinal cord and the surrounding region. We discussed it at length. Should we just open up the spinal cord and not do anything about the untethering? And our doctors said, absolutely not. If you see it, you must remove it. So really our placebo is untethering surgery, and that is you expose the spinal cord, you open up the dura, and you remove all adhesions. But the treatment is with the transplantation in there. Now, this will be double-blind. The patients will not know. The analysts, the data analysts will not know. The surgeons actually are, see the patient only during the surgery. There will be separate examiners for the patients before and after. So this is a true double-blind situation. We're also giving lithium, by the way. I didn't have a chance to talk about this. We found that lithium significantly reduces neuropathic pain and also improves the amount of neurotrophins produced by umbilical cord blood cells in the spinal cord. So we're hoping that we'll see a difference from the lithium, and we can talk about these results. We've already carried out 5 clinical trials. We've done about 100 patients to date with lithium or cell transplantation, and we're now proposing to do a 240-patient trial, a double phase 3 trial around the world. Oh, and I should mention, the cells come from the United States. They're processed in San Diego. They're shipped to China, and the company that does this is StemSite, and they donated all the cells for us.
What else?
I have.
Oh, go ahead.
So this is for Dr. Pettigrew. I mean, how are we going to bring this technology to many more people? It's going to take a lot of money and a lot of expertise, a lot of equipment. How can we possibly do that?
Yeah, Rod. How are you going to do that?
Well, I think there was one word in your question that's also the answer: money. But we certainly need that, not just to have money, but in order to do the research, to fundamentally understand for whom this therapeutic approach works and for whom it doesn't, and then make that available to those subjects that would benefit from it. As I mentioned in my last slide, we are hopeful that we can create a partnership with multiple organizations like the Miami Project that you're very familiar with, and other organizations that have the same goal in mind, and that collaboratively we can generate the funds that are needed to support the range of studies and the quantity of studies that are needed in order to accelerate the delivery of this to other individuals.
Okay, please. Who are you?
Thank you. My name is Nathan from Congressman Frankel's office, and this question is for any of the 3 of you. And I'm sure as research scientists, you probably have a laundry list of this, but what legal and regulatory issues could you cite as the biggest impediments to continued success and goals?
Who wants to go first?
Wow, legal and regulatory. Well, everybody blames the FDA, but I think the FDA is doing a wonderful job. And they are the guardians of the safety of the patients. And I think that they are doing everything they can to encourage these trials, that they're helping. I do think that it may help if there were a law passed to really encourage compassionate use therapies in situations where there's no alternative therapies. Japan recently passed a law that allows cell transplantation research, treatments to be approved based on phase 2 trials if the phase 2 trials show safety and some efficacy, and as long as it does not interfere with the phase 3 trials. Every company I know doing stem cells is now flocking to Japan to do the clinical trials there. In the United States, I know the FDA now has an N of 1 compassionate use approval that they grant within 48 hours. So in effect, this is doable in the United States. Already they're doing it, but it's done on an N of 1 basis, patient by patient. If this could be formulated in a way that encourages companies to do this, to apply for compassionate use, so that if a therapy is effective and safe on a phase 2 level, it can be approved for that purpose for compassionate use until the phase 3 is done.
Anybody else? Okay, please.
Ralph Nitkin, also from the National Center for Medical Rehabilitation Research at the NIH. I guess this question will be for Dr. Bunge and Dr. Young. In both your cases, you showed very robust incorporation growth of the cells you put in there, and it's great. But how come you don't also have some extra activity, some aberrant activity? Do you give credit to the spinal cord for being so intelligent to sort this out and keep it functional? And then during the course of your functional training, the cells kind of prune back into a smaller, more discrete population?
No, you should.
So as far as my work is concerned, our problem, we can regenerate many axons into the implant. But I mentioned the scar, and the problem is getting them to grow out and then to the right area down the cord. So I can't really answer your question. I haven't done enough work to be that sophisticated to answer your question completely. But from my point of view, the challenge is to get the fibers to not only grow into the implant, that is across the lesion, but to leave that area which they love. I mean, we set up such a good milieu for them in the lesion area that they don't want to leave. So we have to come up with ways to lure them from the implant to grow into the spinal cord. And I think that can be done with growth factors, and that's one of the things that we're trying to do. But I can't really answer the pruning question. My work hasn't addressed that.
We're very concerned with possible safety implications of cells growing in the spinal cord. And I just want to say that we've transplanted cells into 41 patients, and half of the cells are actually transplanted into the spinal cord above the injury site where there's sensation and movement. So we monitored those segments very carefully, and there was no loss of function in any of those segments where we had transplanted, which is very reassuring that the procedure is safe. And we transplanted up to 16 microliters in each one of the sites. So we also chose to use umbilical cord blood cells because umbilical cord blood cells have been transplanted in over 50,000 individuals since 1989 for bone marrow and for other treatment purposes. And there has never been a report of a tumor or anything associated with the transplantation of allogeneic umbilical cord blood cells. And so we think that these cells limit their own growth, that they don't spontaneously form into tumors. And we did not expand these cells. These are minimally manipulated cells. They're simply isolated from HLA-matched umbilical cord blood.
Okay, yes, ma'am.
So I'm Lynn Jakeman, and I'm also from the NIH. I'm at the National Institutes of Neurological Disorders and Stroke. And so as a
with a real love for basic research, I'm interested in how does this work? So my question is for Dr. Young, and really I was looking kind of at the time course of your recovery curves, and it looks like the locomotor recovery is happening first, and the changes in bowel and bladder are happening later. As a basic scientist from the beginning of your career, can you expand on what you think is happening?
We're not sure, obviously. But you're right. The bowel and bladder took a year to, when the patients were discharged from the hospital with 3 to 6 months, they were still dependent on assistance. They became independent at 1 year. You would expect a training effect to be present at the time they are leaving the hospital. This is probably a biological effect. At least we believe so. The walking occurred much earlier than we thought. So we're not sure, but what we believe is happening is that some of the fibers are growing across, and they are non-specifically activating the central pattern generator, the onus nucleus, or the sacral nuclei for programmed function. And the bladder and bowel was further down. The CPG is located at L2, but the bowel and bladder is as S2, 3. So we think that this might be the reason for the difference in the timing of the recovery, but all 3 functions are programmed functions in the spinal cord. If we ask the patient to move their legs, yes, they do. They move their legs almost to same extent as was seen in the study with the epidural stimulation. Not quite as well, but almost the same. But in terms of motor score, minor changes in motor score. We did not see a significant effect on motor score.
Yeah, please.
Could I add? Sorry, could I add?
Go ahead.
So I think the work that Dr. Pettigrew described shows that even though an injury has been assessed to be complete, it's not really complete. There are some fibers there that can be awakened. And so I think that might be part of what Dr. Young is seeing, and that is, for some reason, these umbilical cord cells are awakening some fibers that are intact, but they've been asleep. So there's an awakening process, whatever that means.
Yeah, Paul Hooper with Congressman Alex's office. I'm curious, regarding the Schwann cells, I'm assuming that the injury to the rats is fairly recent, and so are you concerned with longer periods of scar tissue that might be less effects associated with that? And I also am just curious what enzyme was used to actually break down some of the scar tissue. And then I believe you mentioned steroid that was also done in conjunction to help the Schwann cells.
Right. So the steroid that we use is methylprednisolone, and Dr. Young mentioned that as one of the first in the trials. And so I think that methylprednisolone is very promising, but I think it has to be locally given, because when it's systemically given, there are some bad reactions to that. We had done a study we published, I think, in 1995, where we applied methylprednisolone, and the implants were beautiful. And this was a complete transection of the spinal cord, not a contusion injury. So we had a gap in the spinal cord, and we got very good crossing of fibers. So I think steroids are important, but I think they have to be locally given. So the enzyme that we used for the scar was chondroitinase, and this is being used by quite a number of people, and it really prevents the formation of the scar. It doesn't so much break it down, but it prevents the formation. And so in some experiments that looks very effective, in others not. But I think one of the complications that we face is a balance issue. So there are all kinds of molecules being produced or broken down or whatever in the spinal cord after injury. And we don't really, we know that TNF-alpha goes up, for example, but we don't really know the full complement of molecules that are there. And so in one experiment, those particular rats may have a different balance than the rats in another experiment in another lab. And so it's complicated in that sometimes there's a very good response with chondroitinase, and other times there is a response, but it's not quite as robust. So I think that it's a balance issue of inhibitory factors and growth factors, and it's very complicated, and we just don't have enough information, in my view. And then you had 3 parts to your question. What was the first one?
Steroid enzyme and timeline
doing it late versus early.
Right. So I think that if we know how to deploy just the appropriate molecules, I think we can attack the scar formation at any time.
Dr. Pettigrew.
Yes, I wanted to follow up with the question that Mary asked me in the beginning about how to proceed. And I gave a fairly quick answer that basically reflected the conversation that I had had with the researchers who generated the report that I talked about in Brain. But I think there's action that needs to be taken at two levels. And it's underscored by the conversation and also the presentations. On the first level, we actually have a technology, at least in the way of the epidural spinal stimulation, that has been well researched based on decades of studies, many of them funded by the NIH, and those I'm familiar with the 2 decades of research from NINDS, who was here, and then more recently from our own institute. That has resulted in a technology that works, as we see from the first cohort of patients that have been reported on, and there have been additional patients that have undergone the same procedure that will be reported on in the future. So we have something that works, and you'd like to make that available to people that could benefit from it. So the initial response was thinking about how to get that out. The major impediment that's been identified from the researchers is that these are expensive procedures to undertake, and that they are capacity limited, and the capacity needs to be expanded. To do that with the current technology that we have, then I think takes some additional funding. The second level really is to get more answers along the lines that my colleagues at the table have been describing, and also my colleagues at the round table out there have been questioning, which is fundamentally exactly what's going on with these different approaches and how is it working. Everything that we've talked about so far is largely a hypothesis, and it's based on the observations that we make, but we still do not completely understand exactly what the mechanism of recovery is. And the research to answer those questions needs to be done, and that will be long-term.
And as you have heard, I'm a proponent of the combination strategy. So I'm wondering about the combination of the technique that Dr. Pettigrew described and the technique that Dr. Young described. What would happen if they were brought together?
We're in fact planning to try that. There's actually a very nice hypothesis, the theory called the Hebbian theory, which basically, put very simply, is that synapses that fire together wire together. In the Hong Kong trial, where we did 8 patients, we did not walk them 6 hours a day, 6 days a week for 6 months. None of the patients walked. In this trial, we walked the patients, 75% of the patients walked. What we think may be happening is that the walking itself induced activity, just like epidural stimulation would induce that activity, and you have to do it a lot, all the time. And we believe that synapses that get down there will not consolidate unless there's activity to consolidate them. And we would like to substitute electrical stimulation for the walking in the phase 3 trial that we're going to do. So we're now talking to a number of companies like Medtronics, Bioness. These are companies that actually have stimulators that have been approved by the FDA, and you also don't have to stimulate it epidurally. You can stimulate these from the periphery. They will also activate reflexive, 1A synapses into the system that would also fire at the same time as the descending pulses fire in. So we would like to take half of our patients in a 240-patient phase 3 trial, and we're going to fit them with stimulators, and we're going to ask them to move their legs at the same time the stimulator's going. If this shows a result, this might be useful. And of course, this can and should be done in animals. And NIH should be funding it.
Here, here.
I'm looking at the round table.
I'm Earl Lane, AAAS. I wonder if Dr. Bunge could talk a little bit more about what the clinical outcome of these 3 patients you discussed with the Schwann syndrome.
This is a phase 1 safety trial, and at this point I can say that it's safe. Beyond that, we're still doing evaluation, and as far as what efficacy we've seen, it's really too early for me to say. But it certainly is safe, as we knew Schwann cells would be, but we had to show it.
Anybody else? So this is, yeah, Rod, go ahead.
Since we have a minute, I did want to point out something from the presentation that I gave that I find particularly interesting. And that is the video of the young man who was moving his left leg for the first time and what he said when he was able to achieve movement. And he said, now I know how I have to think in order to move, but it's hard to remember that, which suggests that he is tapping into some alternate pathway, some system that isn't the routine system. If you think about raising your hand, somebody says, raise your right hand, you do it very easily. But if they tell you to give the Vulcan salute, live long and prosper, you have to think of, at least I do, I really have to kind of concentrate in order to do this as opposed to do this, and I have to think differently about that. And I think it's that sort of thing that's going on with these patients, it seems to me. But it really underscores the need for additional studies to understand how the brain functions, how the spinal cord functions, how the whole neurological system does what it does.
So this has been really, this has been both fascinating and encouraging. Let's thank our speakers. Thank you all for coming. We'll be adjourned. Thank you.
Thank you.